Hello and welcome to Rehab Reels, Conversations on Physical Medicine and Rehabilitation, hosted by Dr. Gwen Soa. My name is Andy Ziegler with the University of Pittsburgh and UPMC. I'd like to welcome everyone joining us today for a special presentation on Frontiers in Regenerative Rehabilitation with Dr. Allison Bean. You may submit questions for our presenters through the Q&A feature on your screen. We will do our best to get to as many questions as possible during the allotted time. Our series host, Dr. Gwendolyn Soa, is the endowed professor and chair of the Department of Physical Medicine and Rehabilitation at the University of Pittsburgh School of Medicine and is the director of the UPMC Rehabilitation Institute. She holds joint appointments in the departments of orthopedic surgery and bioengineering and has served as a clinician scientist in the Department of Physical Medicine and Rehabilitation for over 15 years. Our featured guest this evening is Dr. Allison Bean, a UPMC physiatrist and assistant professor at the University of Pittsburgh School of Medicine. She is board certified in physical medicine and rehabilitation and sports medicine, and her clinical practice focuses on non-surgical treatment of joint, tendon, and ligament disorders, including administration of orthobiologics, such as platelet-rich plasma. Dr. Bean's research focuses on understanding the underlying molecular mechanisms of musculoskeletal rehabilitation therapies to improve physical function. Dr. Soa, the floor is yours.
Thank you, Andy, and thanks to all of those of you who are returning to join us tonight, and welcome to those of you who are new to our group. We have a special treat tonight hearing from Dr. Bean, and it's my distinct pleasure to introduce her. It's not often in one's career where you get to literally observe someone develop into a clinician scientist, and I've had that pleasure with Allison. Having completed her MD PhD here in Pittsburgh, I had the good fortune of being able to meet with her regularly and offer career guidance, and I couldn't have been more thrilled when she decided to go into PM&R. And more than that, I couldn't have been more thrilled when she decided to rejoin us after her residency training as our sports fellow and then stayed on as faculty. So she blends both scientific rigor with clinical pragmatism in a way that is certain to lead to new discoveries that will be readily implemented in the clinic. And this will ensure that she makes a really meaningful contribution, and she already has. She's literally hit the ground running, establishing herself as an important force in this growing and amazing field of regenerative rehabilitation. And we're really thrilled to have her here with us and thrilled to hear about her work tonight. Dr. Bean.
Thank you so much for that wonderful introduction. And thank you to everyone for joining us today. It's wonderful to have the opportunity to speak with all of you. So let's go ahead and get started. I do not have any real financial disclosures related to this work, but I will be discussing off-label use of drugs and devices. As humans, when we suffer a traumatic injury, such as a spinal cord or brain injury, we experience an immediate decline in our function, physically, cognitively, or both. Over time, particularly with treatments such as physical and occupational therapy, we will likely regain some of that lost function. However, as our tissues are unable to heal completely, we are often left with residual deficits that leave us functioning well below our original baseline. In addition to traumatic injuries, we also see declines in our function with aging, with or without an acute injury. For example, our cartilage, which has limited intrinsic ability to heal, begins to wear away, leaving us with osteoarthritis, which I'm sure most of you know can be quite debilitating. As we age, we also lose muscle mass and strength, which can eventually lead to difficulty with walking or performing other activities. Again, current treatments can help, but generally are inadequate to prevent an eventual decline in function. But what if we were able to restore the tissue to its original function? Or what if we were able to prevent degeneration of tissues in the first place? These are the questions that have led to the development of the field of regenerative medicine. While there are many different definitions of regenerative medicine, I think this one from Mason and Dunnell is probably my favorite. They state, regenerative medicine replaces or regenerates human cells, tissues, or organs to restore or establish normal function. Regenerative medicine has the potential to radically change the course not only of diseases that we acquire throughout our lives, but also prevent progression or reverse the effects of congenital conditions as well. So generally, regenerative medicine approaches can be broken down into three categories. The first is organ tissue or replacement. This can include organ transplant, as most of us are familiar with, as well as tissue engineering strategies. Tissue engineering typically combines cells, scaffolds, and biologically active factors in order to create new tissues and organs that can then be implanted into the body and take over the function of the original tissue. Another therapeutic approach that's been widely utilized is stem cell transplantation. With this approach, the hope is that stem cells injected into the site of injury or disease will engraft or become incorporated into the injured tissue and help it recover by differentiating into new cells that will help to reestablish the prior tissue function. The third regenerative medicine strategy that's increasingly studied focuses on the activation of endogenous stem cells that are present within the native tissue, but that may not be functioning appropriately due to age or injury. By applying specific signals, the stem cells can be coaxed back into action and help to restore the tissue or organ to its native state. I will discuss examples of each of these approaches later, but I think in order to understand where the field of regenerative medicine is going, it's important to talk about exactly where we are at now. And so given the importance of stem cells in regenerative medicine, I wanted to take a moment to talk about what makes a stem cell a stem cell. There are two main characteristics that define stem cells. The first is that they must have the ability to self-renew, which means that they are able to duplicate themselves. The second is that they must have the ability to differentiate into different cell types. In this figure, we see an example of mesenchymal stem cells, or MSCs, which are a type of adult stem cell that can be found in many different tissues, such as bone marrow, fat, and muscle. When tissue is healthy, stem cells are typically what we call quiescent, or in a resting state. However, when stimulated by injury or some sort of other mechanical or chemical factor, the cells will become activated. And at that point, they can either divide or to self-renew, or they can begin to differentiate. MSCs have shown the capacity to differentiate into different types of cells, including osteoblasts, which are the cells that make up bone, adipocytes, which make fat, and chondrocytes, which make cartilage. They also have been shown to have the ability to become muscle as well as nerve. It's these characteristics that make MSCs a very common stem cell that are to be utilized in musculoskeletal regenerative medicine research, as they are the key building blocks to healthy tissues. Given the importance of stem cells in tissue regeneration, it's really unsurprising that they have become extremely popular as a potential regenerative therapy. Unfortunately, this has led to a widespread growth of clinics purporting to sell stem cell therapies as treatment for almost any condition. Here we see an ad for a clinic that offers treatment with umbilical cord stem cells specifically for not only all types of musculoskeletal pain, but pretty much everything else as well. From fatigue to headaches, all the way to erectile dysfunction. Notice as well that they say that you can get easy financing. These treatments are not FDA approved and thus are not covered by insurance. And companies often charge tens of thousands of dollars. Additionally, a JAMA study showed that many of these clinics are not actually run by physicians, and even if they are, many of them have not received the specialized training in the conditions that they are claiming to treat. Operating without following FDA regulations is also not benign. There have been reports of serious adverse events, such as patients who have undergone stem cell injections with adipose-derived stem cells to treat conditions like macular degeneration, and they end up losing their eyesight. People have also developed serious infections following joint injections with these unregulated stem cells. And this is due to contamination at the production site. So now, after a period of relative leniency, the FDA is really cracking down on these types of clinics starting this past June. But it's definitely going to be difficult to catch them all, and certainly regulations are much looser in some other countries. Thus, it's very important that physicians and patients are both educated on which treatments are at least cleared by the FDA and which are not approved at all. So many of you who are familiar with these type of regenerative treatments may be thinking, wait, I've heard of reputable clinics, including academic medical centers, that offer stem cell treatments for musculoskeletal problems. And there are actually two types of cell-based biological treatments that are currently offered in clinical settings, usually for cash pay, but these actually may contain stem cells. These are bone marrow aspirate concentrate, or BMAC, and microfragmented adipose tissue, or MFAT, which are isolated from bone marrow and adipose tissue respectively. The devices used to isolate these substances from patients, which are then injected back into the same patient, are the devices themselves are cleared by the FDA, and many of the physicians use them for off-label treatment of orthopedic conditions. But it's important to note that these are not purified stem cells. Indeed, BMAC typically contains only 0.001 or to 0.01% stem cells, and microfragmented adipose tissue is slightly better, but only about 1% of the cells that are contained within it are actually stem cells. While there's some evidence that these types of treatments are beneficial for relieving pain and possibly even for preventing further degeneration in conditions such as osteoarthritis or tendon injury, the quality of the studies that have been published is often quite poor, and much higher quality studies are needed, including laboratory-based approaches that I will talk about today. So before I move on to the science, I just want to make one point clear. Stem cells are not currently FDA approved for any orthopedic application. This comes directly from the FDA website. The only FDA approved use of purified stem cells is the use of hematopoietic stem cells, which are stem cells found in the blood and are used to treat hematological disorders. However, I did go to clinicaltrials.gov recently, and I performed a search for stem cells, and including each of these individual conditions that most physiatrists and rehabilitation experts will be familiar with. Limiting the search to active and recruiting trials, I did find many trials for each of the conditions, both in the US and abroad. Osteoarthritis, unsurprisingly, had the most trials registered, and the majority of these were phase 1 or 2 trials focused on the use of mesenchymal stem cells. While this is certainly exciting, and I remain extremely hopeful that some of these trials will be successful, it's really important to remember that there's a long way to go before these therapeutics make it through full FDA approval, and additional research is likely needed. So I started this presentation talking about how rehabilitation approaches can improve outcomes following injury or in degenerative conditions. In order to further understand the mechanisms by which these therapies might affect cell and tissue behavior, we can go back to our fundamental understanding of biological activity. In the majority of our solid tissues, stem cells are embedded within the extracellular matrix, which consists of an organized network of proteins and other molecules. Cells in the ECM, or the extracellular matrix, are constantly exposed to biophysical pressures, such as tensile forces, compressive forces, shear stresses, and electrical stimuli from nerves and local electrical fields. Cells sense these forces through proteins on their outer membranes that then send these signals through the cytoskeleton into the nucleus. These signals can influence gene expression, stimulate changes in extracellular matrix protein production, as well as induce cell proliferation and differentiation. As these forces change, so does the cell's behavior. It is the cell's sensitivity to the surrounding environment that has led rehabilitation researchers to wonder, can we utilize traditional rehabilitation approaches that alter these physical and electrical forces in order to augment our regenerative medicine approaches? This question has given rise to the burgeoning field of regenerative rehabilitation. By combining these traditionally separate fields of research, we hope to create a synergistic effect, enhancing regeneration of tissues and improving patient function. So for the rest of this presentation, I want to take you back to the laboratory to introduce you to some of the exciting research that is being performed in the field of regenerative rehabilitation. I will focus today on studies in skeletal muscle since that is our laboratory's focus, but there is exciting research going on in all facets of neurological and musculoskeletal disease. The first study I want to talk about today utilizes a combination of tissue engineering and exercise to regenerate muscle tissue. In this mouse study out of Tom Rando's group in Stanford that was published a few years ago, they started by performing an injury on a mouse where they removed a large portion of the tibialis anterior muscle to create what is known as a volumetric muscle loss injury. While mice and humans alike have the ability to repair smaller muscle injuries, this type of injury is quite severe and typically results in significant scar formation, and without treatment will result in loss of muscle strength and function. Following creation of the injury, they took a combination of muscle stem cells as well as other supporting cells that are typically found within muscle and mixed them with a hydrogel. This combination of cells and hydrogel were then seeded into a decellularized extracellular muscle matrix. They then implanted this construct back into the site of injury and sutured it in place within the mouse. After allowing the mice to heal for 1 week, they began an exercise regimen where animals ran on a treadmill for 1 hour per day, every day for 3 weeks. What they found was that 30 days following injury, mice who were injured but not treated with the tissue engineered construct, shown here as sham, non-exercised in red, this group had a very limited recovery of their muscle function as measured by force production. Exercise alone, shown by this brown bar here, did not significantly increase force production either. However, mice that were treated with the tissue engineered construct exhibited a significant increase in tibialis anterior force production, as shown in light green. But importantly, combining the tissue engineered scaffold treatment with exercise significantly increased muscle force production, reaching about 80% of the original baseline. Similarly, when they analyzed gait quality, the animals who underwent treadmill running after construct implantation had significantly improved gait scores compared to those who received the construct alone, demonstrating that the effects of the tissue engineered construct and treadmill exercise were synergistic. The next study I would like to discuss focuses on the combination of stem cell transplantation and a commonly utilized rehabilitation tool. Because many patients may not be able to tolerate something as vigorous as running on a treadmill due to either pain or weakness, we turn back to the rehabilitation field to find another way to generate muscle loading in order to increase strength. For those who may not be familiar, neuromuscular electrical stimulation, or NMES, is performed by placing electrodes on the skin over a particular nerve and applying an electrical impulse. This impulse is carried down to the nerve and induces a muscle contraction. This modality is frequently used in rehab settings to prevent muscle loss or to increase muscle strength, particularly for individuals who have weakness due to a central cause, such as brain or spinal cord injury, but have intact peripheral nerves. NMES has also been adapted for use in mice, generating similar dorsiflexion movements with stimulation of the common peroneal nerve at the knee. So we asked, can NMES produce pro-regenerative effects on muscle similar to treadmill running? In this study produced back in 2013 by my mentor, Fabrizio Ambrosio, they used MDX mice, which have a mutation in the dystrophin protein, which is the gene that is affected in patients that have Duchenne muscular dystrophy. These mice are a useful model to study not only muscular dystrophy, but also muscle injury, as they have a reduced capacity for repair. In this experiment, MDX mice were injected with skeletal muscle-derived stem cells, or MDSCs, that were transfected with LAC-Z, which allows them to be differentiated from host cells when staining during analysis. The contralateral leg was injected with saline as a control. The mice were then subjected to NMES 5 days per week for either 1 or 4 weeks, with each session consisting of 2 sets of 10 contractions for each hind limb. So what did they find? First, one of the major limitations of stem cell transplantation is cell survival and integration into the tissue. Thus, finding ways to increase this is important. As you can see in this first graph, there was an increase in the number of LAC-Z positive cells found in the muscles of mice that were treated with a combination of MDSCs and NMES compared to the group that was only treated with the stem cells. This suggests that NMES improved MDSC survival and engraftment into the muscle tissue. Next, looking at dystrophin-positive fibers, which are representative of muscle fibers being produced by the injected cells, we see that MDSCs alone did generate some new muscle fibers, but that NMES alone did not. However, when NMES and MDSCs were combined, particularly at the 4-week time point, this resulted in a much higher number of dystrophin-positive cells, which suggests a synergistic effect between the cells and the stimulation. And then finally, after repetitive contracture causing a loss of contractile force due to fatigue, muscles that were treated with NMES in combination with MDSCs seem to have a more rapid recovery compared to the control groups, including the PBS controls, as well as the muscles that were injected with MDSCs, but not treated with NMES. Thus, taken together, the results of this study suggest that muscle stimulation using NMES in combination with cell transplantation can enhance muscle regeneration and function in this animal model. So as I mentioned before, stem cell engraftment following injection is typically quite low. Additionally, obtaining stem cells is a very complex process that requires significant time and cost for cell expansion. So the last thing I want to talk about today is some ongoing work in our laboratory that focuses on rejuvenating the endogenous stem cell population using an acellular approach. So to give a brief background as to why we suspect that restoring endogenous function is possible, I want to introduce you to an old experimental technique known as parabiosis. Parabiosis involves suturing 2 animals together so that they form a shared circulatory system. One of the most common ways that parabiosis is used in a laboratory is to study the effects of aging. In these studies, animals of either the same age can be sutured together, which is known as isochronic parabiosis, or this can be either young mice sutured together or old mice sutured together, or a young and an old animal can be sutured together, and this is called heterochronic parabiosis. Heterochronic parabiosis is intriguing, as it gives us insight as to how exposure to either young or old blood can affect different tissues. Back in 2005, Tom Rando's group published a study looking at the effects of age on circulating factors in the setting of skeletal muscle injury. They performed both isochronic and heterochronic parabiosis procedures, and then subsequently performed a muscle injury on each mouse. In these images, the top row shows muscle tissue sections stained for hematoxylin, which stains nuclei blue, and eosin, which stains the muscle fibers in red. The muscle tissue on the bottom shows embryonic myosin heavy chain in red, which is a marker of new muscle fiber formation. And so what they found here is that young animals, whether they were exposed to young or aged blood, so either the isochronic or the heterochronic group, they had a robust regenerative response with greater numbers of regenerating myofibers, as well as activation of satellite cells or stem cells. Additionally, as expected, aged animals which were exposed to an aged environment by their counterpart had a very limited regeneration capacity. However, once these aged animals were exposed to the young circulatory factors when they were parabiosed to a younger animal, they showed a significant increase in muscle regeneration and actually achieved regeneration index and stem cell activation to the same level as the young animals did. So what these results suggest is that there's something in the young blood that is stimulating muscle regeneration in aged animals. However, with this data, the mechanisms are unclear. Is it the cells from the young mice traveling through the circulation and engrafting into the aged mouse muscle? Or is the regeneration solely due to soluble factors that are dissolved in the blood? And so to answer this question, they used a nice approach. They took the young mice that they used for the heterochronic parabiosis were genetically engineered to express GFP, which makes all of the cells in their body grow green under fluorescence. This way, if the cells were coming from the young animals and moving to the old animals and becoming engrafted into their tissues, that tissue should light up green as well. But what they found was that despite evidence of regenerated muscle fibers, as shown by the embryonic myosin heavy chain staining, the aged animals did not show any fluorescence. This suggests that it was not the cells from the young animals that helped regenerate the aged tissue, but that the regenerative effects were instead due to soluble factors in the blood that activated the endogenous stem cells that were already present in the older tissue and thus enhanced muscle regeneration using that mechanism. So since this study was published over 15 years ago, a significant amount of research has been performed towards understanding what these soluble factors might be. Recent studies have identified, excuse my typo here, extracellular vesicles, or EVs, as a potential mediator of endogenous stem cell activation and rejuvenation. Extracellular vesicles are lipid-enclosed nanoparticles secreted by almost all types of cells. They contain proteins and nucleic acids, including messenger RNA and microRNAs. And there is growing evidence that EVs delivered to target cells either locally or to distant areas can alter cell behavior. In particular, studies have shown that EVs that are secreted by mesenchymal stem cells that we spoke about earlier can have regenerative effects, including increasing target cell proliferation, differentiation, and angiogenesis, as well as inhibiting or having protective effects by inhibiting apoptosis, decreasing oxidative stress, as well as decreasing fibrosis and inflammation. So in our laboratory, we have started to investigate EVs, both to understand the endogenous mechanisms underlying regeneration, as well as using EVs as a potential regenerative therapy. In a recent study led by one of our outstanding postdocs, Amrita Sahu, this study was recently accepted to Nature Aging. She looked at how aging affects the ability of EVs isolated from the blood to repair injured skeletal muscle. First, the tibialis anterior muscles of aged mice were injured bilaterally on both sides. And then 3 days later, the muscles were injected either with EVs from young animals, EVs from old animals, or a saline control. 3 days, and then approximately 2 weeks later, the animals were euthanized and the muscle structure and function was examined. So what Dr. Sahu found was that young EVs generally induced a more robust healing response than old EVs. While muscle muscle fiber cross-sectional area actually increased similarly with both EV treatments, both young and old EV treatments, compared to saline controls. She found that a greater amount of collagen 1 protein deposition, which is shown here in red, was seen in muscles injected with aged EVs compared to those injected with young EVs. Increased collagen deposition is indicative of fibrosis or scarring that typically occurs as a result of the muscle injury. And thus, a decrease in collagen formation suggests that young EVs are better able to prevent fibrosis than aged EVs. Aged EVs did have significantly less collagen production than the saline controls, suggesting that they did have some positive effects on preventing fibrosis, but they were not as powerful as the young EVs. Then, it's good to look at histology, but the more important thing in physiatry, of course, is function. So with functional testing, looking at muscle force production, she saw similar findings, as muscles treated with EVs from young blood here were able to produce higher forces than those treated with aged EVs or with saline. Overall, these findings demonstrate that while EVs from aged animals may have some positive effects on aged skeletal muscle, treatment with EVs from young animals appears to improve regeneration more effectively after injury. This has led us to wonder, are there ways to improve the ability of aged EVs to regenerate muscle in order to facilitate their use as therapeutics in a clinical setting? Specifically, can exercise make old EVs act more like young EVs, thus improving muscle regeneration capacity? So there's ample data to support the possibility that this might be the case. Previous studies have shown that exercise can induce anti-aging effects through changes in circulating factors that are released from muscle, and furthermore, that NMES can improve muscle strength and stem cell activity in healthy elderly individuals. And then additionally, work in our laboratory has shown that NMES does actually change the composition of EVs. And thus, taken together, this leads us to the question, can NMES rejuvenate circulating EVs and improve muscle regeneration? So to answer this question, we're now working on a study that has been recently funded by the Alliance for Regenerative Rehabilitation Research and Training. In this experiment, we will perform NMES on both young and old mice for 5 sessions over a 2-week period. Then we will also have young and old controls that will not receive NMES. We will then isolate the serum from the blood of each of these groups and isolate the EVs using size exclusion chromatography, which separates the EVs from the remainder of the serum. In another cohort of aged mice, we will then perform cardiotoxin injection, as I discussed in the previous experiments, and then subsequently inject EVs into the injured muscle. 2 weeks later, we will then perform analyses examining muscle regeneration and the functional capacity of the injured muscle in order to determine the effects of NMES on the EVs. We hypothesize that by altering EV cargoes, NMES will give the aged EVs characteristics that are more similar to young EVs, thus improving their regenerative capacity. By simultaneously studying the changes that occur in EV cargoes, we hope to eventually develop EVs into a clinically utilized therapeutic for treatment of muscle injury and to improve function in aging. So to summarize what we've talked about today, regenerative medicine approaches have the potential to enhance tissue repair and regeneration after injury and in degenerative diseases. However, it's important that we try to understand the biological mechanisms underlying these therapeutics prior to moving them into the clinic. There is increasing evidence that rehabilitation and regenerative medicine strategies combined may actually result in synergistic benefits. And so before I conclude, I want to give a quick plug for the Alliance for Regenerative Rehabilitation and Research and Training Program, also known as ART. This consortium is co-directed by my research mentor, Dr. Fabi Ambrosio, and is a wonderful resource to learn more about regenerative rehabilitation research, both for clinicians and researchers alike. And while I focused only on muscle today, there's a lot more to the regenerative rehabilitation field, including some amazing work being done in stroke and spinal cord injury. Unfortunately, our annual meeting that was planned for November in Austin had to be postponed due to COVID, but there are plenty of webinars as well as some workshops if you're interested in getting more involved. And of course, there are funding opportunities if you have any research ideas. So finally, I just want to again acknowledge my funding sources as well as the whole Ambrosio Lab team. In particular, of course, I want to acknowledge Dr. Ambrosio, who's my outstanding research mentor and has done so much in the development of the field of regeneration, regenerative rehabilitation. I also want to acknowledge Amrita Sahu, who is seen here on FaceTime, but here's a bigger picture of her. She's the one who generated most of the data that I presented today and is also a co-PI with me on the ART pilot grant that we are currently working on. And with that, I will take any questions.
Thank you so much, Dr. Bean, for an excellent presentation on some really exciting work that I do hope will revolutionize things. And I for one, am certainly hoping for that fountain of youth. So while people are thinking of questions, and feel free to post a question in the Q&A, and we'll get to as many as we can. Maybe I'll start off. So one of the things that you talked about early on in the talk was some of the things that are being done in clinical space. And of course, looking back at some of this basic science, I wonder if you could talk a little bit about what are the barriers of taking some of the findings, the very exciting findings that you're seeing now, particularly with extracellular vesicles and STIM and looking at young and old. And what are the big barriers to translating that and getting that into the clinic safely and effectively for patients?
Yeah, that's a great question. So I think that the large number of patient and treatment variables to consider is likely the biggest barrier. If you go to the rehabilitation research, you find that there's an incredible amount of variability in protocols that are used, frequency, time when they're started, intensity levels, and this makes it really difficult to compare between studies. Questions like, when do you actually start therapy after you perform these injections? And what kind of loading is best? Questions like that, I think need to be answered before we start moving these things towards the clinic. Also, there's a lot of biological variables. We talked about aging, but there's also sex, BMI, severity of the injury, the baseline activity level of the patient, for example. And we just don't know if everyone will respond similarly to the exact same treatment. So I think starting at the basic science level can help us answer some of these questions because we have a little bit more control. But certainly things always get messier as you move into clinical studies.
Yeah, I think that the age-old question is how much information is enough to make you feel confident of translating this into a clinical trial, right? There's the discussion of, well, waiting too long prevents innovation, but jumping too fast can put people at risk. So there's always that push-pull between, deciding when there's enough laboratory-based evidence to move something into clinical trial. So I wonder, with that said, patients, certainly when they come to us, have often tried multiple treatments and have often tried multiple, traditional treatments, if you will, or more mainstream treatments. And so I wonder, how do you talk to patients about when they might consider trying a regenerative therapy, and how do you counsel patients about kind of that risk-benefit ratio?
Mm-hmm. So I think by far the most important thing is to always be honest. At this time, there are lots of conditions that we don't have cures for them. And it's certainly always difficult to tell patients, sorry, I can't cure you, when all they really want is to get better. I always try to avoid destroying all hope. as we are making progress in the science and the translation of these therapies. And typically, if they're really interested in stem cell therapies in particular, I try to direct them to the clinicaltrials.gov website to see if they can contact someone in order to get enrolled in one of the active trials, as those tend to be, more controlled, hopefully. Mm-hmm. And then when I talk about the orthobiologic therapies that are currently being utilized in clinics, including ours, such as platelet-rich plasma, and then we don't do this at UPMC yet, but there are places that do BMAC or MFAT, as I had mentioned. I typically just try to tell them exactly what the research shows, that there is some evidence that they might experience a reduction in their pain. And this is typically as a result of reduced inflammation, but there isn't really any evidence yet that they're going to actually grow any of these tissues back with these treatments. I also like to throw a plug for myself and tell them that I'm really working hard at doing this research at the basic science level, so that hopefully in the future I can give them a better answer.
Yeah, absolutely. Well, that knowledge is so important, and I think that it's very clear, even from your presentation today, that even for people that don't have a biomedical science background, making sure that they have the available information and are well informed in making those decisions is part of our job as clinicians as well. So there's actually a question in the chat about recruitment for trials, and if you're doing any recruitment now, and if so, how could people get involved?
Yeah, great question. Unfortunately, right now, I'm more on the basic science side of things. So I'm in the lab doing, animal and in vitro work. But again, I highly recommend checking out, the clinicaltrials.gov website and looking there to see if there's anything that matches your needs. I certainly hope in the future that I can, part of being a physician scientist is being able to do these, do these trials and make sure that things are getting from the bench to the clinic. And so hopefully I will have a different answer for you in the next years.
Yeah. There's a great question in the chat that I hope is coming from a budding clinician scientist, and that's what got you interested in going into this field of work and this direction.
So other than Dr. Soa, so I have always been really interested in musculoskeletal disease. I started research in the field, starting with mostly cartilage back as an undergraduate. I came to medical school thinking, okay, I'm going to go into orthopedics. And then, of course, I saw the light with physiatry once I actually learned about it. But I think that, what really motivates me as a physician scientist is being able to, really combine my knowledge and experience in the clinic and bring it back and inform my basic science studies. There's a lot of, really fascinating research about, underlying biological mechanisms using, stuff like salamanders that are able to regenerate their limbs. But, my goal is to develop a translational laboratory where we can move these therapies more quickly into clinic. So that's really what, gets me going in the morning and keeps me motivated to try to help my patients.
Yeah, it can be absolutely very fulfilling. One informs the other at all times. So another question, kind of career path question, is how much time you spend in the lab versus in the clinic seeing patients, other than how much time your chair will allow you to.
Yeah, so fortunately I have a very generous chair, but currently I spend, basically I have 1 day a week of clinical practice, and then the remainder of my time is performing research. This is kind of, for anyone who's interested in becoming a physician scientist or is currently training to be a physician scientist, this is sort of that like dream split that people talk about, where you have enough clinical time to actually, see patients and, think of interesting questions, but also, especially as a wet lab researcher, that requires a ton of dedicated time. I was fortunate enough to get a grant this past summer that officially affords me and requires this amount of protected time, which is always great to have. But I do find that I really do think that this is kind of the right fit. Certainly there's some surgeons that do more 50-50, but I think that ends up being more like 100-100. But I think the 80-20 split, like 80% research, 20% practice is a really excellent split to have.
Any particular advantages at being at Pitt and UPMC and doing those splits that you see?
I mean, there's, only so many institutions that can support and know how to support people doing that kind of research. We have an extremely robust team, both within the greater Department of PM&R as well as my sports colleagues. And, being able to, constantly talk to each other and discuss patients, discuss things that I'm doing in the laboratory, that really provides a lot of advantage. Additionally, because UPMC and Pitt are such large institutions, there's so many people to collaborate with. It's just incredibly easy to find new collaborators who have new ideas, whether I'm reaching out to them or they're reaching out to me. I'm only starting my second year, but I've, made a lot of great connections, and I look forward to working with people across the institution in different departments as well.
Yeah, I absolutely agree with you. It's just an incredibly collaborative atmosphere, both scientifically and clinically, and it's easy to make those connections and make those connections result in some real work that can be very, very fruitful. So, yeah. So there's a question in the chat about PRP and the variability of PRP and why it tends to work in some patients and not others. Thoughts?
Yeah, that's a great question, and actually something that some individuals in our lab are actually studying right now. I didn't talk much about PRP in the talk, mostly because of time, but for those who do not know, PRP is also known as platelet-rich plasma. And the way that platelet-rich plasma is isolated is by taking blood from a patient or from any individual, spinning it down to remove the red blood cells and keeping the platelets, which have growth factors in them, as well as some plasma. And this is used frequently in clinical settings for several, joint injections, as well as treatment of tendon or ligament disorders. And it has been used for many years. In fact, one of the first uses of PRP was that kind of like rose it to fame was when, and for the Pittsburghers in the audience, in 2008, 2009, when Heinz Ward got a medial collateral ligament injury, and they injected PRP, and he came back from what was supposed to be a 4 to 6 week injury within 2 weeks. And so, it's been, I guess, 12 years now, and the Steelers aren't as good. But what we've found is that, there's been study after study showing some benefits of PRP, but these studies tend to be quite poor quality. And it's likely, as the person who asked the question mentioned, that it's due to the patient variability. At this point, we, simply get the PRP and we inject it right back into the patient, but we don't actually analyze like what their PRP is like and what actually, makes PRP good. So if we have the tools to be able to say like, this is what makes PRP good PRP versus an effective PRP, then we could likely be more effective in our approach and patient choice. But to kind of go back to the question of, what are the factors that influence the effectiveness? There's, like I said, there's actually a study being performed by one of our residents in the lab, Kuntal Chowdhury, and has some funding to look at, what is it in PRP that is makes it effective, and actually, is it the extracellular vesicles potentially? So she's looking at comparing young and old PRP to see which is more effective. And if I had to have a hunch, I would think that old PRP from older patients is likely less effective. It could be that patients that are really fit and active have good PRP, better than their sedentary age matched cohort. But at this point, we really don't know enough to say.
Yeah. So since you have your crystal ball out, let me ask you a related question. And that is, in looking at the EVs, the extracellular vesicles, do you think that there's going to be a key factor, a panel of key factors, or is it the whole soup that's going to be necessary and important in having the optimal effect? What's your thought on that?
Yeah, I mean, I think I doubt there's one single factor. Certainly if we can identify a particular microRNA within an EV that seems to have a more regenerative potential, then we can kind of go with that and see, can we get enough efficacy focused on this one particular thing? But it may benefit us to kind of take a more like panel focus. And it may be that there's 4 or 5 or more different things that make an EV most effective. I know I'm totally hedging on that, but I think we'll have to see, and I think it'll be a combination of understanding the both the EV and its profile itself, as well as the profile of the patient that you're injecting it into. Because it may be that the same EV doesn't have the same effect in different patients.
Sure. So what host factors might be important?
Mm-hmm.
Yeah, in driving that. So what about head-to-head comparison? So what about mesenchymal stem cells from bone marrow aspiration versus PRP? Who do you think would win in that horse race?
Well, I didn't show this data, but there is some, moderate quality studies that show, at least for instance, in osteoarthritis, that between BMAC and PRP, that there's actually not a lot of difference over a 12-month period. This was a relatively small cohort, and there's obviously other factors to look at, but it may be that it's really the kind of the same stuff in BMAC that's helping the tissues that's present in PRP. Mm-hmm. There's actually a clinical trial called the MILES trial that's being headed by Ken Motner out at Emory, where they're not using PRP, but they're looking at different stem cells for treatment of osteoarthritis. So they're looking at bone marrow-derived stem cells, fat-derived stem cells, and then umbilical cord-derived stem cells. And they're actually doing like a pretty intense job of blinding patients, actually performing procedures that, for instance, the patients, they may get bone marrow or they may get like a corticosteroid, the control group, but they'll actually have a bone marrow biopsy performed. So they really won't know what they're getting. And that can help blind, to blind the participants and reduce bias and response. So I think that will help us kind of clarify, at least for OA, osteoarthritis, which treatment might be better.
Yeah, that's great. And that raises the question of stem cells versus the extracellular vesicles themselves. In the event that those might be the secret sauce in the PRP, right? Do you think?
Yeah, it's certainly possible, and hopefully we'll know more soon when the study gets finished. And then, the nice thing about extracellular vesicles is that they are, acellular, and thus they're not likely to generate an immune reaction when they're injected into patients, even if they're, not originating from the patient themselves. They're also really stable, unlike stem cells. And so I can kind of see like a creation of this big like EV depot where you can match EVs to the person's like individual profile, including like their characteristics, their injury, their, what's, their rehab plan, and be able to give them the EVs that are most likely to be effective.
Yeah, personalized regenerative rehab approach, right?
Exactly.
Very cool. Well, I know we're coming to the top of the hour, so I'll leave you with one last question. And that is, what are you most excited about in the future of your research? And are there ways that individual contributions from a funding perspective might actually help your research? These are questions from the chat. So.
Mm-hmm. Yeah, so I think that, I'm really interested in knowing more about extracellular vesicles, and in particular, looking at how different patient factors can affect their efficacy in muscle injury, as well as I'm starting some research in the field of tendinopathy. And particularly, I'm interested in understanding how sex can drive differences in EV efficacy. There's evidence that that sex influences EV cargos and concentration, and so it may be that that this actually can affect the ability of tissues to repair. So I'm really excited about learning kind of about the interaction between sex and also aging, and how these can affect muscle as well as tendon regeneration.
Mm-hmm.
And certainly, funding to kind of perform these studies, in particular, moving towards trying to kind of the big data plan of, using bioinformatics in order to go from like a big picture down to understanding the mechanisms is always incredibly helpful.
Yeah, great. Well, it's very exciting, and stay tuned. Looking forward to seeing some of this data come out, and as you start to get some of these technologies into the clinic. Very exciting and innovative work. So thank you for sharing all of this with us today. Thank you for your amazing work. And thanks to everyone for joining us today, and the wonderful questions that people brought up in discussion. And I'll turn things back over to Andy.
Dr. So and Dr. Bean, thank you so much for such an informative presentation and discussion. For anyone who had a question we were unable to get to today, or if you would like to learn about ways to support the initiatives of the Department of Physical Medicine and Rehabilitation, please contact me at raz37@pitt.edu. Dr. So and Dr. Bean, thank you again. And to everyone who joined us, please be on the lookout for future sessions of Rehab Reels, and have a wonderful evening.